So a very good evening to everybody. We are so sorry for the delay that has happened due to technical issues at our end. So I am Dr. Prabhjot, and I'll be talking to you guys about childhood epilepsy, basically what all the parents should be knowing. I am a pediatric neurologist and I work at Rainbow Children's Hospital, which is in Bangalore, India. So what I'll basically discuss about today is as to what are seizures and what is epilepsy and what kind of episodes, basically what do we mean when we say seizures or seizures in children, what is the
Mm.
recurrence risk of fits in children, what are the commonly used medicines, and what are the common questions that parents usually ask us when they come for an OPD consult or during admission for the seizures. So if you look at what is epilepsy, it is basically two seizures which occur more than 24 hours apart. So unprovoked seizures means two seizures which are occurring without a fever or any other infection. So fits or seizures with fever are very, very common in childhood, and we see a lot of kids between the age of 6 months to 6 years who come with seizures, and these are known as febrile seizures. This is not epilepsy. But if there is no fever and there are two seizures which occur more than 24 hours apart, then it is known as an epilepsy. Sometimes
Okay.
even one seizure can be epilepsy if we as doctors feel that the risk of recurrence is very high. So most of us, most of the parents or lay persons are aware of seizures as the dramatic kind of episodes, which are long, in which the whole body starts to jerk, and it usually
Okay.
involves both the arms, legs. The teeth is very tightly clenched. The eyes are rolled up back. So this is the kind of image that we all have in our mind that this is the seizure. But in addition to that, there are a lot of other kinds of seizures that can happen. They can be sudden, fast jerks of the body, with after which a child just falls down, or there's just a sudden head drop like this, or the child is standing
Hello,
and
doctor.
suddenly he falls. Hello.
Doctor, we can't able to see your screen, doctor.
Oh, wow. What should I do then?
And I raise my hand to ask a question.
Are you able to see my screen now?
No, no,
Okay.
doctor.
So anyway, see, I'll go ahead. So and to try to carry on.
Okay.
Okay. Um, so, like I was saying, there are a lot of kind of episodes which can actually be seizures in children. They are this big, scary looking episodes. They can be sudden drops. They can be sudden entire body flexion, which can happen. And sometimes it can be episodes just like staring look, in which kids will just stare at one point. And sometimes they may zone
Mm.
out all of a sudden when the seizures are happening. Okay.
Mm.
So it's very, I'm so sorry that we are having all these connectivity issues. Are you able to see my screen now?
Mm-hmm.
No,
Are you
ma'am.
able to see? Okay.
Yeah, babe. You see? You No. Can't see it.
Okay. This is very difficult. I don't think it is going to work. Okay, so I think there's no internet connection at my end. Can we do one thing? I think there are a lot of parents who have joined in here. So I don't think the presentation is going to work. What we can do is parents can ask me questions and I can answer them. So basically, we are looking at questions about epilepsy, seizures. So if you guys have any questions, we can just go on and discuss the questions. We can do that because I don't think my presentation is going to play. Hello.
Doctor, I suggest you can just
Can we ask the
explain us
questions now?
without the.
Sorry.
Doctor, I suggest that you can explain us even without the presentation. I suggest you to explain everybody so that
Okay.
they
So I can
understand.
do that. I'll go around a few concepts or few things that we usually encounter in the OPD, and then I think parents can ask questions. So, like I was telling, that most of the times we think about epilepsy as being one of those big seizures, that dramatic kind of episodes, but that is not always the case. Sometimes you can have even very brief seizures, certain simple things like just staring at one point and not responding to you. Multiple times the children can just zone out and not respond immediately. This can also be a seizure. Sometimes, especially in smaller kids, 6 to 8 months old, you can get sudden full body jerks like that, or complete body flexion, or going into a kind of a spell like that. That can also be a seizure. So, seizures can take a lot of forms in childhood. If at all there are any concerns from your side as parents that okay, this does not look normal to me, I do not think this movement is abnormal, do go to your pediatrician with this concern that okay, is it fit? So that is one thing. And after that, most of the times when parents go to their doctor and tell that I think my child is having fits, so most of the doctors will ask you to describe as to what is happening. So we usually ask parents to tell us exactly what happened so that we can kind of recreate in our minds what is going on. Because this is the most crucial information that helps us to make a diagnosis of epilepsy or of a seizure. Rest of the things, the investigations that we do, they kind of help us beyond this point, but the diagnosis, whether it is a seizure or not, is usually attained from the history or from the events that the parents describe to us. Many times, many parents do come in with videos because there's a lot of availability of video phones these days. So this also help us. If there are videos, then we can see the event itself, and then we come to know what is the diagnosis. So beyond this, most of the times the doctors, as doctors, we will ask that, okay, after this, we want to do a few tests. So mostly we prescribe something known as a EEG or electroencephalogram. So same way, like we look at the electrical activity of the heart, like somebody has a heart attack and we want to look at the electrical activity, we do something known as an
Mhm.
ECG. That is something very, very common. So the doctor looks at the ECG and he tells you that, okay, this person is having a heart attack. Similar way, if we have to look at the electrical activity of the brain, then we do a process known as EEG. Now, this EEG is not something which tells us whether it is a seizure or not. But yes, if I know it is a seizure, the EEG gives me additional information. It tells me, is it a specific kind of epilepsy? Is it an absent seizure? Is it a focal seizure? That means the abnormalities are coming from one part of the brain or not. So many times parents, when they come to us, they request that, okay, doctor, please do an EEG and tell me whether my child has fits or not. So EEG helps us once we make a diagnosis of fits or epilepsy or seizures from what parents tell us. And beyond that, to classify it further or to get additional information, we do an EEG. So that is the first thing that we do. The other thing, many times your doctor may ask you to do is a brain scan. Now, this brain scan is again of two types. There's something known as CT scan of the brain, and then there's something known as MRI scan of the brain. No, it's a very common thing. Parents will have a scan and they'll be like, okay, we have this scan. So doctor, tell me, why is the scan done? So CT scan and MRI scan both are like a photograph of the brain. CT scan is something that we do in emergency situations. Like let us say a child has come and he's sick. He's having very high grade fever or he's not responding very well to us. He's in coma. That time the CT helps because we can diagnose things like if there's a brain infection, is there a brain bleed in the brain which is causing the fits, and it is done very quickly. It takes hardly 5 minutes for us to do the CT. On the other hand, it does not give us a very clear picture of the brain. So, if a child has been having seizures multiple times and it is not something that has suddenly happened or it is not an acute thing, the child is otherwise okay, we would prefer to do an MRI because MRI gives us a much more detailed information about the brain. So, these are the first two tests we do for any child who comes to us with seizures. Beyond this point, many times we will just start the children on medications and see how our children are responding to the medications. If the fits get controlled, there are no further seizures, we would want to continue these medicines and not really do a lot of tests. But then we kind of modify this thing according to the situation. If you have a very small baby, let us say we have a baby who's just been born, or a baby is 2 or 3 months old, then probably we'll do a lot more tests to diagnose why are the fits happening, as compared to an older child who is otherwise well and has had come with 1 or 2 episodes of seizures. In which case, we will probably do these two tests, put on medications, and then continue with the continue follow up and see how our child goes. Now, another questions that parents usually have is that, doctor, do I really need to put my child on medication? So, to understand why we put our children on medications, we have to understand that what is the risk that if my child has 1 episode of seizure, what is the risk that is going to have a seizure again? Now, there are two ways of looking at it. Sometimes there are seizures in which the whole body is involved, something that we tell parents it is a generalized seizure. So, if this is the kind of seizure that a child has had, the chance that he'll have another seizure is hardly 30 to 40%. What it means is, if there are 10 children who have a full body seizure, the chance that this child is going to have another seizure, out of its 10, only 3 or 4 is going to have a repeat seizure. So what many times we do is if a child presents with this generalized whole body jerking kind of a seizure, we usually wait. We may not decide to put the child on medications upfront. However, if two of these seizures happen, then the chance that a third seizure is going to happen is very high. So there's a 80 to 90% chance. That means if 10 kids have had two seizure episodes, there's almost 8 or 9 of them are going to have a third episode also. So after 2 episodes, we definitely start treatment. That is the first thing. Now another thing is that sometimes the fits are only one-sided. So let us say only the left arm is jerking or the eyes are going to the left side. So this is something known as a focal seizure. Focal seizure, even in the first episode, the risk of recurrence is high. Then also we start treatment in the first course. So we start the anti-seizure medicines. Beyond this, there are certain epilepsies, like maybe some of you have heard of terms like absence epilepsy, myoclonic epilepsy. With these kind of seizures, we may want to start the treatment upfront also. That is, when you come to us the first time, we make a diagnosis, we start a treatment because we expect that these episodes are not going to stop otherwise, right? So this is how we go about starting the treatment. Now, coming to the treatment, the mainstay of treatment for fits is the anti-seizure medicines. Now, we choose the anti-seizure medicine depending upon what is the kind of fits that our child is having and which medicine we expect should work the best. So that is a decision that your doctor takes according to what kind of seizures the child has. So once we start the seizure medicines, there are usually few rules that we follow. So we usually start it at the lowermost dose. So most of the times, this is the conversation we have when we are starting medicines. That once we start medicines, we expect and we hope that the seizures should stop. They should not come again. But it is never 100% thing that okay, it is never going to come again. On this dose, the seizure may recur. So what do we do in case it recurs? First of all, we give only one medicine. We start it at a low dose and then we go to the maximum dose of this medicine. Once we have gone to the maximum dose of one medicine, only then we consider adding another medicine or changing the medicine if the seizures are not well controlled. Now, what do we expect from the parents, or what can parents do from their side? The one thing that parents should ensure is that the medicine is going regularly. So, howsoever your doctor has asked you to take medicines, we take those medicines. We do not try to miss even a single dose. There are few other things also which the parents need to be very, very careful about. One of them is that always check the medicine that the doctor has prescribed and the medicine that the chemist or the pharmacist has given you are correct, because that is very important. Second thing is, most of the doctors, we tend to write the concentration also. So if you have Dipakine, we might write Dipakine in brackets 200 mg 1 ml. In India, the preparations that we have is 200 mg in 5 ml. So the concentration varies. The concentration may be different. So it is very important that we give the correct concentration so that the dose that our child is getting is absolutely correct. That is the first thing. Second thing is, we always write the dose in ml. So we will usually write 2 ml, 4 ml, 5 ml, morning and evening. So we never write teaspoon, we never write cup, we never write one bottle cap. So try not to use these things for giving seizure medicines, because the dose becomes incorrect. So we want you to, if possible, we want you to buy a syringe which has got specific markings on it, 1 ml, 2 ml, 3 ml, specifically measure the medicine and then give it to your children. So these are the usual things that we follow. And also, once we start medicines, we usually want that the same brand should continue. So if you're buying Dipakine, buy Dipakine only. Don't go to Valparin. So because the medicine, which the actual medicine that the child is receiving or is going into the child's body and is acting might differ as you buy different brands. So that is another thing that we want the parents to be careful about. Now, coming to the next common question. So, see, seizures are something that is extremely scary for the family. It is extremely scary for the child, and it is extremely scary for the parents. So, we want the parents to know, to be empowered as to what to do when the first seizure comes. So, as a reflex for most of the parents, when our child is having a seizure, it is so scary. We panic so much that we, at any cost, we want our child to start responding to us. We want this episode to stop. So we do a lot of things. We'll try to shake our child. We'll try to put water on our child. We'll try to, splash water on the face. Sometimes we'll slap our child that in an attempt to wake him up. Sometimes we end up giving some fluid in the mouth, medicine in the mouth, water in the mouth, so that we feel that, okay, this might make my child better. But as a rule, what we want is that whenever the child is having, the first thing is take a deep breath. We don't want you to panic, so that we can ensure that you are able to take care of your child better. So whenever the seizure is happening, try not to panic. Take a deep breath. The first thing that you wanted to do is make your child lie down. Do not pour water, nothing to be done. Make him lie down, turn him to one side, which is known as the recovery position. I wanted to show it in my presentation, but you can always Google it. What is recovery position? So make your child turn to one side and try just to make him in that position for some time. See, the logic is that whenever your child is having a seizure or any person is having a seizure, that time the consciousness is lost for some time. So we do not have control over our breathing, over our swallowing. So sometimes even the saliva which is in the mouth, it can go into the lung pipe and it can cause choking. It can make the breathing difficult for our child. So we don't want that happening. We want you to turn to your child to one side so that whatever is there in the mouth, it should come out by gravity. So nothing should remain. That is the first thing that we do. Now, the second thing is, we never want our child to have a long seizure. So what do we mean by long seizure? Long seizure means more than 5 minutes. So if the child is having a seizure for more than 5 minutes, at that point, we want you to have a medicine that should be able to stop the seizure. In India, we usually have a nasal spray, which we can put in the nose. The dose your doctor will specify, and we can use that medicine to stop the seizures. The alternative thing, when this was not available, is something known as a rectal suppository. So we put it in the anus and we wait for the medicine to act, and the seizure should stop. So usually the seizure should stop in a couple of minutes or maximum up to 5 minutes. So next thing, when we tell this parents that, okay, this is what you have to do. So the parents will be like, okay, doctor, when do you want us to bring our child to the hospital? So my child has a seizure in the middle of the night. Should I immediately rush to the hospital or can I wait for the next day? So if it is a brief seizure, by brief we mean it is a couple of minutes, definitely less than 5 minutes, you can wait. You can wait at home till the next day, but come definitely next day, see your doctor. If we have an episode which is going on beyond 5 minutes, you have had to use the nasal spray to stop the seizure. After that, the seizure has not stopped. That is the point that you really need to come to the hospital immediately at whatsoever time. More than two episodes happening back to back, yes, you need to come to the hospital. Any long seizure which is not getting aborted at home, we need to come to the hospital. So this is the point when we want that okay, parents should come to the hospital. Acha. Beyond this, so these are the common things like what we do when we have a child with epilepsy, how we treat, what are the parents to do at home, what are the common precautions to be taken when you're giving medicines. Now, another common question is that can my child have normal activity? Can my child lead a normal life? So that is a definite yes. So although there's a lot of taboo regarding this topic, a lot of parents and society as such considers that okay, a child who has epilepsy will not be able to lead a normal life. But almost 70 to 80% of people with epilepsy do lead an absolutely normal life. So your child will be taking medicines, but he can go to school, he can do his normal day-to-day activities. It is not a problem. You can continue with normal diet. The diet does not have to be changed. But there are few activities which we definitely want should be monitored, especially kids. Like if a child is playing at heights and it is unprotected heights, there is no railing, nothing, and the child has a seizure, he may fall down and hurt himself, which can be life-threatening. We don't want that happening. So this has to be supervised. If you send your child for swimming, it has to be under individual supervision. In fact, we usually tell our parents that let our child be okay, let it be controlled for at least a few months, beyond which we restart these activities. If a child is going for cycling, then it is better to have protective gear, to have a helmet, elbow, knee pads, which can prevent the injury. And even cooking and all needs to be individually supervised so that a child does not end up in a situation which can be life-threatening for our child. So these are the common questions which I felt I usually encounter in our OPDs. So I think beyond this, parents can ask questions if they have any. I'll be very happy to take questions.
Can I ask my question now?
Yeah, please ask.
I've got a 9-year-old child who
Okay.
suffered from seizures from
Okay.
the age of 2. So what he used to do when you are still a newborn, he would be shivering, right?
Yeah.
And I actually thought that he cold, like he was feeling cold, because when I
Oh.
was pregnant, I couldn't wear anything, like I was feeling hot.
Hmm.
So now they picked up that he's got seizures when he was about 3.
3 years
Anyway,
old.
to cut them, yes. So to
Yeah.
cut the matter short, um, he suffered from seizures from the age of 3. Then
Okay.
they put him on medication. I'm from South Africa, and they gave him the Epilim to stop the seizures.
Okay.
6 months later, they continued. He had like episode, which
Okay.
lasted for like an hour, and
Okay.
then they changed the dosage again. But
Okay.
now, when they changed the dosage,
Hmm.
he became so hyper because of the syrup that they gave him. But
Okay.
now he's 9 years old. He hasn't been. The seizures have stopped. I could say they
Okay.
stopped. I'm
Okay.
wondering if there's something that I could give to him because now after he's been on that medication, that was
Mm-hmm.
supposed to stop the seizures,
Mm-hmm.
he's hyper. Yes.
Okay.
So
So
are
from
those part of is it
okay.
the side effects that comes with the medication?
Okay. So from what I understand
Yes.
is that he's now 9 years old, and I suppose he has been seizure
Yes.
free for more than a couple of years now.
Yes.
Okay. So see, once our child is, I absolutely understand many of these medicines, which are seizure medicines,
Mm-hmm.
can actually make our children hyperactive. So at this point, we usually sit back and we try to assess whether it is the medicine which is making the child hyperactive or is it the epilepsy per se, because both of the things can be present. If the epilepsy is well controlled and we
Mm-hmm.
predominantly feel that it is the medicine which is making a child hyperactive, we can try to put him on an alternative
Mm-hmm.
medicine. If it looks like
Okay.
alternative medicines are not working well for him, and this is the only medicine that really works well for him, then we can start additional medicine for controlling the hyperactivity and maybe start behavior
Okay.
therapy also. But before that, if I have a child who has been seizure free for more than 2 years, I would like to reassess,
Mm-hmm.
can I stop the medicines altogether or not? Is it possible or not? So it probably would
Mm-hmm.
depend on why is my child having epilepsy? Is there underlying brain problem? Is there a structural problem? And all those things probably which your doctor would have assessed. So at this
Mm-hmm.
stage, we would want to see that is it possible to take him off meds? If it is not possible
Mm-hmm.
to take him off meds for the epilepsy, we would want
Mm-hmm.
to assess for hyperactivity part and add
Okay.
a medicine for that or alter the seizure medicines and see how it goes from here.
Okay.
Yeah.
And another question.
Yeah.
Um, I recently had a baby,
Mm-hmm.
so she was 8 days old, and she
Okay.
also started. I don't know what is it. She was also shivering. So I
Okay.
took her to hospital, and they did the blood culture, but everything seemed to be normal.
Okay.
However, when they did the scan, they said she's got a grade 1 bleeding in the brain. So is it possible that later in life it's going to develop into epilepsy or seizures?
That will have to wait and see. See, the many times, yes, brain bleeds happen in small kids, but
Mm-hmm.
there's a good chance it may completely resolve if it is a very small bleed, and it may not result in anything later on in life. On the other hand, if it is a really big bleed and it has caused some amount of brain damage, it may or may not
Mm-hmm.
result in epilepsy. So it is not a hard and fast
Okay.
rule. Many of the kids who
Mm-hmm.
have brain bleeds as small babies tend to do extremely well. So yeah, for this we'll have to just wait and see.
Okay.
Yeah,
Okay, doctor. Thank you so much. That's all I
yeah,
wanted to know.
yeah.
Yes. Okay.
Thank you.
Vlogs, if anybody have any questions.
Hello, doctor.
Yeah.
My question is, if someone has seizures, does that he or she mean suffers from epilepsy?
See, if there are more than two seizures which have occurred good 1 day apart, the diagnosis is that of epilepsy. So epilepsy is nothing but more than one seizure happening. Okay. So yes, it technically makes it epilepsy. Hello?
Okay.
Yeah.
Okay, doctor.
Hello, doctor.
Yeah.
What happens if I leave epilepsy untreated?
See, there are a lot of things, especially in kids, it may lead to behavioral issues. Uncontrolled seizures in themselves can lead to a lot of complications. There may be loss of school days, there may be loss of cognitive abilities, loss of the way you work at school. And untreated epilepsies, there's something known as sudden risk of death in epilepsy, which is uncommon. It is 1 in 5,000 kids. So if 5,000 people have epilepsy, one of them can have a sudden death. But in pediatric age group, untreated epilepsies can lead to a lot of developmental delays, behavioral issues, difficulty in schooling, difficulty in education. So yes, we really want to treat epilepsies well.
Okay, doctor. What are the precautions to be taken by epilepsy patients, doctor?
So most of them, like I already said, for pediatric patients, especially playing at heights should be supervised, swimming, cycling, these all need to be supervised. And school also, the emergency medication should be at hand. The parents should ensure that they carry the SOS or the emergency medications or nasal spray if they're traveling out. And the school needs to be informed about this seizure medicines. Be very careful about the seizure medicines that you're taking. There should be correct dose. They should not be missed, and the quantity should be appropriately measured and given.
Yeah, okay, thank you, doctor.
Okay.
If anybody have any questions?
Hello, ma'am.
Yeah. Hello.
Yeah, I saw the fact that nearly 80% of people with epilepsy live in low or middle income country. What do you
Okay.
think, ma'am, the reason for that?
So the reason for that is predominantly probably we have a lot of neonatal issues which happen. So the neonatal care is not very good in the low and middle income groups in these countries. So a lot of children who can be potentially saved and potentially do better in developed countries are the ones who are prevented from brain damage at the time of birth. Kids who do not cry, do not get sufficient oxygen when they are born, ultimately tend to have developmental delays and can have epilepsies also. So that is one part. Second part is there are a lot of tropical diseases, there are a lot of infections which happen in our middle and lower middle income countries. So these infections can have devastating effects. And a lot of vaccinations which can prevent these, many vaccinations which can prevent these diseases are not easily available at acceptable cost, or they are not a part of the universal government-led immunization programs. So that also adds on to the burden of brain damage that our patients or our people incur. So it leads to ultimately higher incidences of epilepsies in our countries. So yes,
Oh,
we
okay.
expect as these things get better, the epilepsy rates should come down.
So there's a vaccine for that, right?
So there are few diseases which are preventable. There are few diseases which may not be preventable even in the developed countries. But yes, if we are able to prevent even this preventable brain infections, we expect that the consequences of this infection should be less.
Oh, okay. Okay, thanks.
Anybody have questions?
I've got a question again.
Yeah, sure.
So with the seizures and the epilepsy, is it hereditary?
Then again, it may be hereditary, may not be hereditary. So the children who
Okay.
present with very early fits, and there are some specific subtypes of seizures or epilepsies which may be genetic. A very large majority of epilepsies are not genetic. And now we need to understand there's a difference between genetic epilepsies and inherited epilepsies. So genetic basically means if there's some defect in our DNA makeup, we can get an epilepsy. Now, there are certain genetic disorders which may run in families, which is then it becomes inherited. So many of the times there are genetic epilepsies which come for the first time in a child and they may not be present in the family.
Okay,
So,
and does the child inherit it more from the mother's side or the father's side, or how does it
no.
work?
It varies depending upon the underlying epilepsy. So many of them, most
Okay.
of them, the genetic epilepsies may come from either parent or from both parents. So I think there's a lot of bias in that. That many times a single parent is blamed for the epilepsy, but that is absolutely not true.
Because that's the first question they ask you, like, is there anyone who suffered from the epilepsy from your household? So one would think that maybe it's probably coming from the father's side, because from my side, we don't have anyone that suffered from any epilepsy. You
Okay.
get what I'm saying?
Okay.
Yeah.
So see, it like I told, it is not a hard and fast rule. The genetics can come from either family, but it is not a hard and fast rule that it will come more from the mother or from the father.
Okay, doctor. Thank you.
If anybody have any questions? Okay. Thank you, doctor.
Okay,
We are really glad that you could take time out and conduct the much needed webinar on epilepsy awareness. And I also thank the participants for attending today's webinar. If you want to consult any doctor, you can contact Anavara. We encourage you to connect with us on social media. If you have any additional questions, you can contact us by email or telephone. We are happy to provide you additional support. Thank you. Thank you, everyone.
Thank you, everybody. Bye.
Thank you, doctor.